Invite Dr. Manju M. She is a glaucoma consultant working in Arya High Hospital, Thrissur. She'll be talking on false alarms, early misses, visual field limitations in early glaucoma.
Good morning all. The talk is on false alarms and early misses, the visual fields limitations in early glaucoma. So we'll start from what is glaucoma. Glaucoma is defined as a disturbance in the structural or functional integrity of the optic nerve that can usually be arrested or diminished by adequate lowering of the intraocular pressure. So for the diagnosis of glaucoma, we should have a structural, that is the optic nerve head analysis and the OCT analysis, and also the visual functional analysis is by the visual field analysis. The functional analysis is usually by the visual field analysis, and a normal visual field is defined by TACWare as an island of vision surrounded by a sea of darkness. It is 60 degrees superiorly and nasally, 70 degrees inferiorly and 100 degrees temporally, and the blind spot is located 10 to 15 degrees temporal to the fixation. So usually done by the perimetry, that is systematic measurement of the visual field, by the standard automated perimetry or white on white perimetry. So when you do a perimetry, there is a fixation target, usually a central fixation target. And if you don't have a central fixation in such patients, you can see a small diamond there. So you can tell the patient to focus on the center of the 4 points of the small diamond, or even there's a peripheral large diamond also. And usually we use SITA standard, Simulus 3 white with fixation target center. You have other options like SITA fast, which is a quicker method, and also even SITA faster method. So you do what usually is a 30-2, which has 76, which tests 76.6 degrees apart, and then 24-2, which we usually do in glaucoma, which tests 54.6 degrees apart, and 10-2, which has more points like 68 points, 2 degrees apart, which focus on the central area. And if you are planning any surgery, better to do a macular program with 16 points, 2 degrees apart to see whether there is any macular split or split. And for those who we are suspecting any central field defect, you can do a 24-2C, where 24-2 is with an additional 10 central test points. That is the 24-2C. And this is how the HFA report is. And now we have short wavelength automated perimetry, which is a blue on yellow perimetry, which can detect early visual field loss before standard white on white perimetry. Now, what are the early, now we are dealing with the early glaucomatous field defect. It can start with a nasal step. Here you can see, here it is 0 and it is 19. So there is a difference in the nasal side, that is it's a 24-2 field, but the nasally it is up to 30-2. So here, sorry, 30 degrees. So here there is a dip. So it is a relative depression of the horizontal hemifield compared to the other. That's an early glaucomatous field defect, is a nasal step. And you can have a small island of relative or absolute vision loss in 10 degrees, central or paracentral scotomas. And this is like almost like an early arcuate scotoma, but usually arcuate scotoma start from the blind spot like this. If you have an arcuate scotoma, it's not an early glaucomatous defect. It comes as more like an advance. Starts, it's an arcuate scotoma that starts from the blind spot, arches above or below the fixation, and reaches within 1 degree of the fixation, and it can extend up to nasally up to 20 degrees. But it does not cross the horizontal divide. That is the most important thing. So coming to the topic, the visual fields, what are the visual fields limitations in early glaucoma? One thing is that in early glaucoma, patient can have high retest variability, because the patient is having a learning effect. And there can be a structural damage often that precedes the functional damage. Same as I mentioned, there can be a learning defect that can cause false progression or more false positive or false negative effects. And there can be localized early defects which can be missed on if you do only a standard 24-2. There can be defects that is closer or central area which can be missed in 24-2. And there can be patient-related factors like which can reduce reliability in early disease. So this is like a generalized depression. You can see in the total deviation plot there is depression, but the pattern deviation plot, which is more specific for glaucoma, is okay. So if you only focus on this total deviation plot, it's like a false alarm. And here you can see a dense defect present in the contagious region or peripheral region, like a rim. This is due to the lens rim artifact. The trial lens which we use for the HFA is causing a rim artifact, which will be seen as a peripheral damage. It's like a false alarm. And here you can see the patient is having a high false negative errors. And because of that, that is 80%, because of that, you see a clover leaf pattern. And it's due to the patient inattentiveness. But if you are not careful, it will be like a false alarm. You may think that the patient is having glaucoma and proceed with the treatment. And you can have like white scotomas if there is high false positive error, as you see here. And if you have high false positive errors, there is a chance of missing field defects. So it's like maybe like an early miss where you may miss genuine field defects. And this this case, this is a 68-year-old patient who was on AGM in the right eye. But the left eye patient was not on any anti-glaucoma medication because everything seemed to be normal. But if you see here, if you incorporate that with the structural damage, that's what we are stressing. You can see a RNFL loss in the superior part of this OCT. And definitely if you observe, you can see a small slit-like RNFL defect in the patient. So if you only focus on the visual field, this is like an early miss. And this is also a 70-year-old patient, not on any anti-glaucoma medication, and it was like a borderline defect. But if you see the OCT, you can see there is a definite inferior RNFL loss with a wedge-shaped RNFL thinning. So this is or like a pre-perimetric glaucoma only if you incorporate the OCT and correlate structure and function, then only we will be able, otherwise we will be, it's like an early miss. This also field is completely normal, but here is a small defect, RNFL defect, and you can see it's not that visible, but there is a small RNFL, wedge-shaped RNFL defect in the optic nerve. So we are not saying you should start the treatment or anything, but in such patients, you can follow up the patient more frequently and you can tell the patient there's a chance of a glaucoma and follow-up is needed. And in this patient, the patient is having a small nasal step-like defect. But structurally, if you see, there is no RNFL defect. The ganglion, GCC also normal. CCT is 544. So everything is normal. This is due to the high false negative errors. It's like a false alarm. If you see only the field defect, it seems like a nasal defect. This patient was frequently having superior field defect, but the structural loss was not corresponding to the visual field defect. The patient was having a ptosis. So because of this ptosis, patient was having a superior field defect. So it was like a false alarm. So how to rectify this? Better to have the structure function, always correlate structure with function. Repeat baseline field, supplement if 24-2 you are taking, and if you see any field defect in the OCT, better to do a 10-2 also, and always optimize patient factors like dry eye, anxiety, refractive error, and also do multiple tests and analyze progression if you have any doubt. So I'm just telling the structure function correlation. Here, if you have any field defect, this is the area where there can be a field defect by the structure, and if you see the same in the field defect, this is like a structure function correlation. So we'll move to the last. So this is like a visual field. It's a baseline visual field. If you repeat it, the field is normal. So this was like a learning effect. So to conclude, the take-home messages will be like false positive fixation losses and learning effects can reduce the reliability of the visual field. So structure function correlation is mandatory. So if you see any central macular defects, better to do 10-2. Multimodal imaging is important. Repeat testing and to improve the reliability, and you can have AI enhanced techniques also. Thank you.
Thank you, Dr. Manju, for that